Get our recording started. So welcome everyone. I'm very happy to have our presenter today, Candace Owen, and she is currently the National Network for Oral Health Access, or NOHA, NOAA's Educational Director. She is a dental hygienist, and as I mentioned, currently at NOHA. She previously was a professor at the University of New Mexico in the Department of Dental Medicine, and her focus was on interprofessional education. She received a master's in dental hygiene and an MPH degree in dental public health at the University of New Mexico. And Candace will be speaking today about the integration of oral health and primary care practice. So welcome, Candace.
Great, thank you so much.
I'm going to assign you, I'm going to pass over the keyboard control for you so you can advance the slides.
Great, okay, I think I have them. So, well, thank you for joining today on the call for the integration of oral health and primary care practice. I am here on behalf of NOAA, but also in partnership with the Equitable Care for Elders. And what I'd like to do today is talk a little bit about what NOAA does as far as our integration work for medical and dental. So a little bit about us. We were founded in 1991 by a group of dental directors who worked in federally qualified health centers, and they identified a need for peer-to-peer networking, collaboration, research, support, and leadership in regards to the safety net setting. And so our mission is to provide support, advocacy, and leadership to oral health providers in the safety net setting with the goal of improving oral health access for underserved populations. We are a membership organization which includes more than 3,000 dentists, dental hygienists, supporters, and partners. And we have a lot of resources available to everyone in regards to the safety net setting, but also some other topics. So if you're not working in a health center, we do have some resources that are relevant to your practice. So we are a HRSA Training Technical Assistance NCA grantee, so a lot of the work that we do is funded by HRSA, but we also do some work on the other side of things. So here are some resources that we have to offer. We provide learning collaboratives such as this one throughout the year, one on integrating oral health and primary care practice. We also have one specifically on the UDS sealant measure. And then we also have another one on quality improvement, and we are accepting applications now for that one, which will start in September time, so in the fall. That's on our website, and that one's going to just focus on improving your sealants as well as some other quality measures like caries at recall and risk assessment. So we also offer some operations manuals. There's a total of 6 of them, and they're on different topics that are focused on the practice or the management of health center dental programs. So there's some on financials, some on leadership, quality. So those are available on our website. We also offer webinars throughout the year. We just had one on our dental dashboard, which is on quality improvement, but we also will have one on payment reform in July, as well as one on integrating oral health and primary care practice, which will be in August. So those are free to anyone. We also have a listserv, which is very active. So if you have any questions about oral health or dental programs in the safety net, anything from your EDRs or from policies or protocols, that's a really active place, and you can join that on our website as well. We also have promising practices that we release. We have one on dental therapy that will be coming out this month. And just from your peers on things that they're doing and some best practices there. We also have a dental forms library on our website, which includes some things like peer review examples, some policies, job descriptions, as well as educational materials for your patients and providers. So our website is listed there, noaa.org, and we also have an email, which is info@noaa.org. So if you have any questions, you can contact us through that way. So, oh, went too far. Let me go back. Okay, so a little bit of history on our integration oral health collaborative work. So we had, back in 2011, the Institute of Medicine released their second edition of Improving Access to Oral Health Care. And in that, they had recommendations for HRSA to release some core clinical competencies for primary care providers on oral health. So in 2014, in response to that, HRSA released this white paper on their integration of oral health and primary care practice initiatives. And so in this white paper, they outlined 5 oral health core clinical competencies, and they also discussed the need to translate these competencies into the safety net setting. And so NOAA, being a partner with HRSA, we released this user's guide in 2015. We call it our IPOC guide because it's the implementation of interprofessional oral health core clinical competencies. So it was a pilot project. We worked with 3 health centers throughout the nation, and they implemented these 5 oral health core clinical competency domains with their primary care providers. So in this guide, it includes some promising practices, some oral health measures for quality and sustainability, and also some ideas for training, implementation, and standardization for primary care providers. So these are the 3 health centers that we worked with to do this pilot. And so Health Partners of Western Ohio, Bronx Community Health Center in New York, and then Family Health Care in North Dakota. These are the 5 oral health core clinical competency domains. So there are, the first one is risk assessment. So that's asking questions, the primary care providers asking questions about oral health to the patient. So that includes, you know, do you have a dental home? When was the last time you saw a dentist? Do you drink fluoridated water? And then the second is oral health evaluation, and so this is that screening piece. So we're not necessarily looking for providers to diagnose, or primary care providers to diagnose oral disease, but to recognize oral disease. So recognizing inflammation, recognizing decay, recognizing the need for the referral. This third one is preventive intervention. So if you're able to provide fluoride varnish during the medical visit, especially with children or patients who are high risk. The fourth is communication education, which is that conversation between the patient and the provider. And then the fifth is interprofessional collaborative practice, which is essentially referring across disciplines, so referring from medical to dental. This is from the Virginia Oral Health Coalition, but I think it's a great visualization of what can happen if we have true integration. So if we're focusing on mainly medical and dental, which is the first step, you can see how there are oral health activities that go to other aspects. So oral assessment completed by both medical and dental, medical asking some oral health questions, but dental doing some medical activities like blood pressure screenings or diabetes screenings. And then there's that referral line at the bottom that goes to everyone. And we have to remember that true integration is bidirectional. So it's not just medical to dental, but also dental to medical. And then they also have different disciplines listed: behavioral health, pharmacy, as well as social support services, which are all important aspects when we're talking about true integration and true overall health. So within our IPOC guide in 2015, we identified 4 systems that were needed for the implementation of the core clinical competencies. So the first step to success really is planning, and so that's identifying your champions, developing a team that's going to be working on this project, as well as a timeline when you want this to really be going full force. And then the 4 steps follow that. So we have the training systems, which is training medical providers on oral health, the HIT systems, which is how your EDR and EMR speak to each other, but also how do you leverage your EMR for effective integration. Clinical care systems, that's the workflow piece, and then evaluation systems, which is the making this sustainable at quality improvement, metrics, etc. I'm just going to do a little deep dive into some of these systems. So the first step is planning, like I was talking about, and you want to also look to see if there's any synergy within your organization that you could piggyback this on. But if not, then you can start from fresh, and that's great. We also recommend that you start small if you're going to start doing some integration work. So start by selecting one site. So if your organization has multiple sites, pick one, and then also select one population of focus, whether that's diabetes, pregnant women, children. Just pick one population to start this integration initiative on. That way you can test for anything that needs to be improved, and then you can move forward by implementing it with your whole patient population. As far as training goes, there's really two aspects of this. It's online training or in-person training. Online training, there's a lot of great online curriculums that you can utilize that are already standardized. But also, online curriculums allow it to be self-paced, which is helpful for providers with their busy schedule. But also in-person training, so whether that means having the dental providers come in and giving a quick training on how to apply fluoride varnish or what questions to ask during the risk assessment portion. And we recommend using a combination of online and in-person trainings. And then how do we make this sustainable? So onboarding of new health professionals means that how are you going to integrate this training into your new hires? So this is one example of a online curriculum. So this is Smiles for Life. It's considered the nation's most comprehensive oral health training for primary care providers. It's also endorsed by a lot of organizations, including NAC. And so you can see how they have 8 modules online. If you're working with one specific population, you can just pick the modules that are relevant to that. So if you have children, course 2 and 6 are probably the best. If you're working with diabetes or adults, 1 and 3, and then pregnant women, course 5. For the health IT systems here, we have, this is talking about how you're utilizing your EMR for integration. And so in order to implement these 5 domains, your EMR must be able to do these things. First, you want to include a risk assessment tool that automatically scores. I'll show some examples. And then also, you want to have an area to document that screening aspect so that providers are guided through that process of the screening, but also to document what they find. Also being able to document any preventive interventions that you're doing and being able to track those, self-management goals, and patient education as well. It also would be great if your medical record could print out educational handouts and post-visit instructions that include oral health. Oftentimes it just has medical because it's a medical appointment, but starting to integrate some oral health aspects to that. Also, your EMR should be able to refer patients to dental care if you have dental care on site, being able to do that, track those referrals, and document the referrals. And then obviously having your EMR be able to pull reports so you can collect that data. So here are some examples of some screenshots from our pilot project. And so if you look at the top here, we have risk factors and protective factors. This is within GE Centricity. You can see how the providers are prompted to ask some questions about the patient's risk, but also what they're doing at home. So are they drinking fluoridated water? Are they brushing their teeth? So this is for kids, but you could always change it to work with adults. And what they had is they leveraged their entire team. So they had the medical assistant ask these 2 top questions or 2 sections, and then the medical provider would come in and then do the rest. And so now you can see the box that says clinical findings. That's that oral evaluation piece looking in the mouth. And they would just check yes or no if they see any obvious decay or any restorations, any inflammation. And then based on those 3 boxes, it would auto-score. So it would auto-score their risk to be low or high, and so you can see on the assessment plan on the left-hand side, it says carries risk. And based on that risk, if they were high risk, it would prompt the provider to apply some fluoride varnish. There's a little button that says administer fluoride varnish, and they could click on that, and that's how they would track if fluoride varnish was being completed during the medical visit. And then if you look under carries risk, there's a little box, and it says referred to dental services, and so that's how they would track referrals. They would just check that box. And here at the bottom are the patient instructions, so you could click on any of these that you think are relevant to the patient, and then you can print it and give it to the patient to go home with it. And so this screenshot really shows all of the different 5 core clinical competency domains on one page and how that can be done. So this is the clinical care systems now. So this is from our pilot project on the left domain tasks. Those are the 5 core clinical competency domains, and then each of the health centers, the 3 health centers, what they decided to do to distribute their workflow. So for risk assessment, you can see how you can either use your entire support staff, so like medical assistants or front office staff, to do the risk assessment, or you could have the provider contribute. For the oral evaluation, all health centers decided to have the provider complete it. For preventive interventions, they had the support staff complete this. So if there was fluoride varnish being applied, only the medical assistant would put it on. For communication and education, the provider would give it and then provide some take-home materials. And then for interprofessional collaborative practice, which is a referral, the provider would do the referral using a checkbox in the EMR. But some of them decided to do different things to ensure the patient was getting the appointment scheduled. So the patient would take their little, for the first one, they had a laminated yellow tooth that they gave to the patient. The patient would go up to the front desk and give the tooth to the front office staff, and the front office staff would be indicated that they needed to make an appointment. So things like that can be done. This is another screen from GE Centricity. It just shows how the referrals are made electronically. So they had a lot of different referrals that they could make, but then in in-house services, they offered dental, so they would click on that, and then it would generate the referral. And then there's that picture of the yellow tooth there showing how that tooth was given to the patient, and then the front office staff was notified to make an appointment. The last system is evaluation system. So we have 8 minimum set of measures for integration work. So the first 3 are really provider behavioral changes. So is the provider starting to do some integration? Are they doing true integration by completing this? So this is how you measure that. Number and percentage of oral assessments or screenings performed by primary care providers, the number and percentage of fluoride varnishes applied for high-risk patients during the medical visit. Then number 3 is essentially the same, different oral health preventive interventions provided during the medical appointment. So that includes nutritional counseling, tobacco cessation, oral cancer screenings, or fluoride varnish. 4 and 5 are red because that's really what we want. We want dual users. We want the same number of patients referred from medical to dental to be getting definitive oral health treatment. So in the ideal world, if you had full 100% integration, number 4 and 5 would have the same percentage. If you're referring 50% of your patients, that means 100 of them should be getting, or 50 patients should be getting oral health care treatment. And it's important to define this measure. So what does definitive oral health care mean to you? That doesn't mean an emergency visit or a limited exam. That means a comprehensive visit, a periodic visit, a prophy. What does that mean? So defining that type of measure. Then 6 through 8 are just outcome measures, so quality of care, the knowledge and skills of primary care providers that can be gathered through a pre and post survey, or you could do, at the end of Smiles for Life, you get a CE certificate that shows that they completed some type of assessment at the end of their training, so that could be your indication that there's some change in knowledge, hopefully, and then also the patient experience, and you can gather this information through patient surveys. So from our pilot projects and the collaboratives that we've done with integration, these are some lessons that we've learned. One complaint is the time for training. The providers, primary care providers, saying there's not enough time for me to do all this extra training. And so having a self-paced online curriculum like Smiles for Life is beneficial for that. Also, if there's no interoperability between your EDR and EMR, you want to develop some different ways to track and document what you're looking for. So if the issue is I can't track referrals from medical to dental because we're using 2 separate records, then finding different methods, whether that's using some type of Excel spreadsheet to track them in the meantime, using paper referrals, that is those are some workarounds in the meantime while you work out those issues. And then also speak to your vendor, because a lot of times there are some bridges that you could have between your dental and medical record. The lack of capacity. So if you are referring all these patients to dental, but typically dental capacity is far less than primary care capacity. So they may not be able to accommodate all of these patients that are being referred. And so that may mean long-term expansion of your dental program or contracting dental services. But also you can try doing some dedicated appointments, so dedicating some time slots for medical referred patients. Patient resistant to dental treatment. A lot of times they're like, well, I'm here for my medical visit, I'm here for my primary care visit, I don't necessarily want to talk about dental. And so doing some motivational interviewing and talking to them about the relationship between oral health and primary care, how they relate to each other, can help with that resistance. And it's the same for the medical providers. At the end of the day, the medical providers want reduced A1C levels, they want reduced diabetes, they want reduced risk for premature births. So talking to the medical provider about how oral health relates to those general health concerns and how treating oral health can often be that little tipping point for them when it comes to A1Cs, or if they're eating healthier, that helps with their obesity, but it also helps with dental caries. And so just having those conversations with them, and then we'll find that we're all at the same goal. And so that's pretty much all I have. I just want to send out a quick reminder that our annual conference this year is in New Orleans, November 11th through the 14th. Our registration will be open at the end of, or towards the end of June, beginning of July. And we'll have some sessions on integration as well, but we're also open to having some of you all be speakers for our 2019 conference. So if you're looking for some opportunities to share what you're doing, please feel free to look out for some abstracts next year. And thank you all so much for your time. Here's our contact information. I have my contact information and then also our dental consultant, Irene Hilton. And are there any questions right now?
This is Lenny Brennan. I have a question if you have time for it.
Sure, yeah.
In a lot of private care, if we do not have like Medicare services, one of the problems that we have is that even if they're identified in primary care, there's no referral. The ability to refer to. Does this work? Or is it most of this has been done in states that have, or in areas where that you have coverage for seniors?
Yeah. So I think that a lot of what we have here can be applied. So I know that, if they're only on Medicare, they're not going to have dental coverage. And so there are different organizations, especially health centers, that have different, payment options for individuals that don't have insurance or don't have coverage. And so looking into, developing a partnership with those type of organizations who may have sliding fee or may have grant money that they're taking patients for no cost. And then also, like, academic partnerships are always great. There's always dental hygiene students who are looking to provide perio treatment and whatnot.
Well, that's a good recommendation. I was talking to some primary care docs over the weekend. One of their concerns about even starting a program like this is they'll identify and not being able to refer. And in Maine, and a lot of the states, that's their hesitation. Instead of looking at it as, let's get this program started, identify, gather the data, and hope that some of these resources come along. But that was very helpful, Candace. That was great.
Great, thanks. Thanks so much.
Thank you so much, Candace. I know you have to run to another learning collaborative, so I don't want to hold you up from where you need to be.
No problem. Well, thank you so much for having me. I really appreciate this partnership. And if there's anything that comes up, please feel free to email me and we can talk anything through.
Great. Thank you so much.
Yes, thank you.
And have a good rest of your day. And
okay.
so I will, once I gain control of my screen here, I will let Candace go. And we will send out Candace's slides, which were extremely informative in terms of thinking about integrating oral health into primary care. And it looks like also Paula has joined us as well. So I wanted to open it up. So thank you, Candace. And I just wanted to open it up for any questions. We can talk a little bit more about what Candace had mentioned. And then Len, I also wanted you to react to what Candace had mentioned in her presentation with the older adult lens in terms of integrating oral health in primary care.
It's a more difficult situation than with kids, because with children there has been a real historical effort to bring children into a care situation, and there's been finances and there's been services that have opened up for children and for some young adults. The same has not happened with adults. So one of the problems that you have even trying to implement this type of a model into existing primary care docs is that once it's identified, they have virtually no referral sources that will take these patients. And we've talked a couple times during these sessions on the dilemma is that so many seniors do not have the ability to pay for services. And so that if they're referred to some type of a dental setting, they can't afford the treatment. So two things happen. They tend not to go for treatment. So there's not a lot of data on those even reaching the primary care offices. And there's not a lot of data on the implementation of integration, since the end source of getting the patients into dental settings is really successful. So it is a challenge, but I think one of the points that Candace made, which is just excellent, is that you have to start and work your way up that ladder, and being able to go in and develop these programs and get their systems in place are so important. Knowing that if primary care is going to be the #1 access point to oral care, it has to be integrated into the oral care, to the primary care setting, even if we do not have a referral source from there. So many behavioral changes for patients could be adopted just going through the primary care system, even if there's not a referral system after that. So I think it's such an excellent approach, and I think data shows that it can make a big difference for patients and their oral health and for their overall systemic health. So it's a large problem, and knowing that only 17% of the 17 states really have a system that you can see senior patients in their states. We have so many states that really do not have the options for care.
I would agree. This is Paula. I was really impacted by a picture that was shown at the NOAA conference last year about we've got to stop separating the head from the rest of the body for oral health care, and that really has put an impact on me. And I took it back to my health centers this year about talking about that, because I think part of our hurdle is getting some of our more established medical providers to remember that we have the services here to help people. But you make a really good point that it's, I think it was Leonard that was talking, that there's no resources for these folks. And so we've gotten lucky in one case, in that we have a church who has created and donated, and it's not much, but it helps us. $1,000 fund for older men. I forget where the money came from, but they designated it for basically 65 and older. We've had to lower it to 55 because we've had trouble spending it, but 55 and older men because they have no coverage, and and so it's been really helpful. But it was really nice that they, for whatever reason, found that to be a target area for them, and so they don't. So it's used at one of our sites. We have 10 different sites that offer dental, and so it works with that one. But we've thought about really monitoring that and looking at it as and tracking that data to be able to use and maybe go after some other groups, because one of the things we're very concerned about with HRSA is, everything's on opioid and diabetes right now.
Yeah.
And no dental, and I'm struggling. I'm an administrator, and so I'm struggling with, my dentist feeling burned out because we only feel like we can afford one dentist at a site, and there's no light at the end of the tunnel. That every day it's more people with need than we can certainly meet, and the expectation is that we're just going to be able to see everybody. And so I have dentists that are feeling very burnt out and stressed out, and so it's really hard to kind of figure out where is this funding to help meet this need. So I appreciate everything you guys are talking about, but we've been really lucky with this church to help this one site, and are really looking to see if it's something we can target other small places to get people to understand that there really are no resources for people with dental, and it does make a huge difference to get these folks in on their whole general health.
Yeah, that's a really interesting idea in terms of connecting with other organizations, particularly the faith-based, to kind of backfill for services that aren't covered in other capacities. And it's interesting because I wonder, as we're thinking about trying to build some sort of readiness assessment around health centers' readiness to care for older adults in general, but with respect to integrated care, and thinking about the relationship between medical and dental and behavioral health, as well as social determinants of health. It's possibly connecting with other organizations, and what the capacity to connect with other organizations that may see value in having services available to their community members. It'd be really interesting to find out from that church why they thought originally 65 and older, and then bringing it down to 55 and older men for dental services. What their thinking was behind that, what value they thought providing those additional resources would bring to those individuals.
Yeah, I'm pretty sure it was a men's group at a church.
Oh.
Which is why it probably Staples, was focused on that. It's a rather large church in an urban area, and I think for whatever, but I'd be curious as to particularly why they did that. I think this is the second year. We got it last year. They approached us, and they renewed it again this year. And so I will have to ask, because I am curious.
Yeah, when you find out, please share that, because it's certainly a really interesting approach in terms of bringing in the funding necessary for you to be able to do what you need to do.
That's
yep, I will.
One other point on that, Paul. Congratulations for you for doing that, because those resources are still available, and many times we don't approach those churches or other organizations. But I know just personally, when I actually approach them, I don't think I've ever been refused in 40 years. People will say, well, and there can be, some will say, how do we put these people back in the workforce? And it may be giving them teeth and a smile, or it could be, but it can be not only the adult organizations, but high schools with a Key Club and those types of organizations have also stepped forward to provide services. So I think one of the things is we have to have the courage to ask, because many times they do say yes. So that's just a great idea.
And I think you can make the case so well of the difference someone who has a good smile or, you know, healthy teeth, the difference it can make in their life about how they, you know, how much more confident they are, how better, let alone the health benefits or how it attributes and works together with chronic diseases as well. But just for those folks who, you know, would come in and just, well, I don't have the money, so just, you know, pull them all and I'll do without. And it's like, no, what can we do for you to try and save this? And you can turn a family's dental health care around in a generation by doing that. Because we do have a children's dental program, and, you know, our children's dentist is like, if I can get these kids to have good health, there's the mom's teeth and here's the kids' teeth, because, you know, we transport them from the school. And so it works out really well, but it's like we can really turn that around by getting those kids good oral health care habits right from the start and make a huge difference. And, you know, and then we'd love to, you know, and so luckily, because we have this children's dental at one, we can also refer mom over to the other health center for adult care, but it, you know, it's still tough to get them in, and like you said, the resources. You know, it's always amazing to me that Medicaid, we did not expand Medicaid, and they're certainly not going to expand it for dental, but at the same time, you know, if you get a bar fight and lose a tooth, Medicaid will cover it if you're covered, but they won't cover regular, and it's like, then why does this make sense?
I have a question for you, Paula. When you have your physicians that are in the healthcare center, does it stimulate, like when we're making a connection between primary care and oral health, when they're educated and then there's training sessions on, you know, managing the disease and then looking at, you know, the oral disease that can result, you know, from, it could be diabetes, hypertension,
right,
and then the disease itself then exacerbates loss of teeth, means maybe you have an inflammatory process, you can't chew your food, so then you tend to go to softer foods with lots of sugar, and then everything gets worse. Does that type of line, that timeline, does that encourage physicians to participate more?
I'll be honest with you, we are struggling with that in general, that they get it when they hear it, but I'm also, so here's what we've done. We've done integrated with, we say we have this integrated model. Behavioral health has integrated well with both medical and dental. We have seen benefits of behavioral health with keeping people in the chair, reducing white coat anxiety, lowering blood pressures, things like that. The dentist and behavioral health have worked really well, so people don't have to walk out of an appointment or get seen. Or they'll work really well with medical and dental if somebody's high blood pressure. But we're struggling to get medical, and maybe you know, it's always the, oh, you've got so much on us for all our UDS measures and everything else already, we don't have time to do dental. But it's like, but somebody can look and see when their last dental appointment was. So to back up to that, I'm really working with our dental director now to be more of an advocate, to talk about this and how can we do it and how can we work one-on-one with providers to do it. Our behavioral health person was a real champion for the integrated model. And so that really helped make the change. We switched dental directors, and we had a very passive dental director who took her cues from the medical director who was a more established medical director and wasn't necessarily getting on board with it. But then this new dental director came and she just bulldozed over everybody. And before you know it, we've got, you know, and then she empowered those other very advocate, champion type behavioral health practitioners at our offices to get more involved. And so that's how that worked. And now it's trying to get dental to say, remember how they were such proponents for the care? That's what you guys need to be. And how do you do that when you're stuck behind a chair all the time, but you know, because you're so busy, but we've got to make that case in a more proactive, better way and start getting everybody on board. And so last year was the first year, for whatever reason, we had never heard of NOAA as a safety net provider. I'm a fairly new CEO, and I had seen something, and I'm like, does anyone know what this group is? Why are we not participating with them? This sounds like where we're supposed to be. And so one dentist and I came out to the national conference last year, and so this year I'm coming out again, and I'm bringing my dental director, another dentist, and I'm hoping to bring my director of clinical operations along so that everybody can see, because I thought the sessions were great, and I was like, you know, we need to stop thinking of dental just as an aside. Dental is part of this overall healthcare. So it's one, I would say it's coming from the top, but it's hard with the medical folks to get them to kind of buy into this part of it. It's like, but it's just like anything else. If you have a diabetic that needs their vision care, they are diabetic, they need to get their dental care. Why not refer them to us? Why aren't we making it so that that diabetic patient gets priority over, you know, someone in the community, so that we're taking care of our patients and getting better outcomes for our patients, and then hopefully moving them on and then making room for another patient to come in. But so we're really struggling with that. We're struggling with how to schedule. I mean, it's a struggle for us of how to integrate dental and get everybody working together on that, because people don't want to leave time, you know, they don't want to leave spaces for people to be seen right away or have a warm handoff because they want to stay busy and they've got enough no-shows everywhere else. So we could probably talk about this for days, but so we're struggling, but we're passionate about it. We're trying.
That's fantastic.
I have a question. Do I have time for one more question there, Christine?
Sure. Sure, go ahead.
I have a question. I was talking to primary care docs, and I was asking, these are private care docs, what was their greatest obstacle on integration for them? Those three separate ones. Mm-hmm. And one of it's not they were against integration, but they said on some of the older patients, it's so hard to even bring them into the practice to manage them medically. Mm-hmm. They have a hard time just getting through that part of it without trying to integrate it to somebody else, and they would kind of grade themselves not successful in integrating a lot of these senior patients, and sort of asked me, well, how do we now take these patients and move them into dentistry when we're having a hard time recapturing them medically? Do you find that to be true? I would agree that so often they come in or they don't come in regularly enough that you're right. They're seeing, you know, how are they going to pay for that? Do they pay the medical copay? If we try and do it the same day, can they afford 2 copays? No. So, you know, what's the value? And that's where we, I think, as an organization, need to talk about what is the, you know, what resources do we have to put towards improving the outcome for the patient and meeting the patient where they are. So if we have a responsibility and we're going to preach that it's, you know, all of our patients need to have these services and we offer them, and you know, we've got these UDS measures that need to be improved and things like that. So what concessions can we make, or who talks to that patient? Is that the care coordinator? Is that part of the care team? We talked a lot with behavioral health about because we had one provider, it was funny, about a year into integration, the medical provider finally looked at one of his peers who was doing well with it, and he said, how do you tell your patient they need behavioral health without making them think they're crazy? And it was like, oh my gosh, that's been your stumbling block? You didn't know how to do this warm handoff? Okay, well, let's talk about that. We talk about the fact that it's, you know, it's a team approach and it's behavior modification in a lot of cases. It's not counseling necessarily for trauma or something like that, but it's behavior modification. So if you've been seeing this diabetic patient and not getting their A1C, getting them to move the needle on that, and all you've been doing is adjusting medication, or you know they're not doing it, don't keep spending your time and spinning your wheels and knocking your head against the wall about why does this happen. Let's go refer them to the behavioral health person so she can talk about and get to that about, well, why are you not taking your medication? What's keeping you from being compliant? Or, you know, whatever else. And so right now we're also working, we got a grant from a small private foundation that's working on what they call defeating the deadly duo, which is diabetes and depression. And in that, they're expecting us to get them to vision and dental as part of our overall care of these diabetic patients. And so I think it's more, you know, so it's really talking to everybody about this, but it's really, you know, I think sometimes the medical providers just do get wrapped up in everything that they have to do for their patient and try and get done with all the quality measures and data they're supposed to collect, knowing they may not see this patient any more this year because the patient may not get here. And so that's why we're really trying to, you know, figure out how we can do more care coordination. How can we do more follow-up to meet, you know, yes, part of us is trying to meet value-based payment issues, but it's also
how do we get all these services to the patient, and getting the patient to understand you have this whole team of resources when you come to us. This is the benefit of coming here versus going to private practice or doing whatever else. When you come here, you have a whole team of people. And I heard somebody talk at a session about how impressed a patient was when they had a call about their situation, and the behavioral health person was at the table. You know, they have set time to take care of these patients, group that they're managing. And so they were all on the phone, and they said the impact on the patient that all these people were working together to take care of her was incredible, you know, for her to finally realize that all these people matter. And so I think some of that is getting the patient to understand it's not just a relationship with the provider, but it's a relationship with all of these people here to support you. And sometimes that takes the provider being willing to step back and say, it's not just about me, it's about all of us to help you. And that's hard for some providers. The younger providers are coming out of school in a team-based approach, but but that's been a transition in the medical school. So some of our more senior providers who've gone through medical school a while ago still think it's all about them. And so that's hard.
Yeah, that we might see this transition with the medical school's standards.
Because a lot of them are teaching integrated models, so they come out expecting it. And like the best thing, we had a PA that said that, you know, we didn't think was going to do it, and she made the comment, she said, I don't know that I want to go work anywhere else that doesn't have an integrated model now that I see what it can really do. You know, and again, a lot of that was at behavioral health, but it's like we got to bring dental to the table too, and make sure they understand this is part of it too. And so, how do we adjust our schedule to make that happen? Because when we, like I said, with this champion for behavioral health, one of the big things we did was we actually stopped really seeing outside patients, because one of the complaints the medical providers had was we have all these patients who have needs, but they can't get in to see you because you have all these other patients that are getting referred here from outside sources for behavioral health. So we said, okay, but for this to work, medical, you need to refer, because we can't, as an organization, have our behavioral health providers sitting around twiddling their thumbs because you're not referring when you said that was the reason you couldn't refer. So there was kind of, you know, there was a slow, you know, it took a while. We took a dive in productivity, and then, you know, we've grown back up. But so it's working for us now, but we did have to make that commitment, and we haven't been able to make that decision in dental. And I'm sort of hoping when I bring this group to the NOAA conference in November that they'll hear from some other folks of how they make this work.
Great. Good point.
Yeah, that's amazing. I'm really surprised and encouraged to hear about how you've been able to integrate behavioral health not only with primary medical care, but also with dental. I think that's.
Well, I will give this. So this is my goosebump story, and what I tell like my new employees and stuff about why this works is because we had a situation at one site where the dentist saw the child for her regular cleaning and noticed she had a pretty significant rash, eczema type issue on her arms, and she was I think like preteen child, but so she referred that child over to the doctor, who was finally able to take care of and resolve it. But in learning all of this, learned that this child had real self-confidence issues because she had this skin rash, and as you can imagine, kids can be mean. And so we got her into behavioral health, and we're like, that's why this system works. We took care of that. We all worked together and took care of this child, and look at what we did for her. We got her teeth fixed, we got the rash fixed, and we fixed her self-confidence. This is what it's all about.
One other thing, Paul, you know what I want to make more? People like you make integrated care work. You're a great story.
Yes, that is.
You're a great story.
Yes, I mean, well, I appreciate that, but but that's why it works, and that's what sets us apart as health centers from just your private practice, is that we're here, and you've got this great resource. And you think about our patients; they have transportation issues, they're single parents, they don't want to go running all over the place, and we're right here, and we all work together.
Exactly, and the same thing with older adults as well. It's so much easier for them to have. I hate to use the phrase, but it's apropos. One-stop shop. Where they're not going all over the town, the city, the village, wherever they live, going from appointment to appointment, particularly if mobility is an issue or transportation is an issue.
Exactly.
And also, you know, they have then a community of people that they know is looking out for them as well. So thank you so much, Paula. This has been a really interesting conversation. We're so glad that you were able to join. And we really appreciate the time that you've taken, and it looks like it's 12:59. And so if you have any questions after this, before our next session, or even just sharing some of the things that you did today, please feel free to reach out. And so I will end our session today, and thank you again so much.
Sure, no problem.
We really enjoyed talking with you and hearing about your program and what you've been able to accomplish.
Oh, great, no problem. Yes, I appreciate these calls. They're helpful.
Great, great. Well, thank you so much, and have a good day, everybody.
Thanks, you too.
Thank you.
Bye-bye.
Bye-bye.